Hello, my name is Brian Lin, co-director of the Center for Asian Health Research and Education at Stanford, and I'm pleased to welcome you to another of our series of Asian Health Talks every month, co-sponsored by the Stanford Health Librarian. I'm very pleased to welcome Dr. Sun Kim today. Great thanks before we begin to the Vincent V.C. Wu Foundation for sponsoring these talks. Sun Kim, MD, MS, is a board-certified endocrinologist who specializes in the treatment of type 2 diabetes, polycystic ovarian syndrome, and obesity. She's particularly devoted to helping individuals change their lifestyles and achieve sustained improvements in their health. Please join me in welcoming Dr. Kim.
Thank you, Dr. Lin, for that nice introduction. This is really a topic near and dear to my heart, and I'm so excited to be able to talk to you about type 2 diabetes in Asian Americans. I know Vincent Wu was someone who really believed in giving back to the community, and I'm really excited to be able to do that for the Stanford community as well as the community at large. So many of you are undoubtedly familiar with the fact that individuals with diabetes are increasing throughout the world. And the top 3 countries include China, India, and the United States. They're really the most populous nations. Today, we're going to put a lens on the United States, particularly focusing on the state of diabetes in Asian Americans. So I'm going to be answering some questions, but I thought it would be good to start out with some definitions, such as who is Asian American? What is diabetes? What are risk factors for diabetes in particular in the Asian American population? And how can we decrease this risk? So first, if you're joining me, you are probably very aware that the term Asian American refers to a diverse group of individuals. Currently, the Census Bureau defines Asian Americans as having origins in 3 regions: East Asia, Southeast Asia, and South Asia. And this is not an exhaustive list of countries, so please forgive me if I've left out your favorite country. I'm going to be particularly focusing in on 3 countries in each region: China, the Philippines, and India. I thought this statistic was interesting because a lot of times you find that data presented on Asian Americans are aggregated because of the fact that perhaps we're a small portion of the population, but that is going to be changing and is changing. If you look at current census data, the numbers of individuals classified as being Asian American has doubled since 2000 to 2019, and that includes about 22 million individuals, and that is projected to increase. There are certain groups that make up the majority of the Asian American population, and the top 3 origin countries include China, India, and the Philippines. And for that reason and other reasons, I'm going to be focusing on those groups. Another interesting thing to consider about Asian Americans, and it really does pertain to health as well, is that Asian Americans are majority, over 50%, are born in another country. And then adults who are Asian Americans, that number is even higher. By comparison, approximately 14% of all Americans were born elsewhere. And then another important lesson we've learned, especially through the pandemic, is the effect of what we call social determinants of health, such as income. And then you may hear that Asian Americans generally have higher income compared to other populations in the United States. However, I want to remind everyone that it's not true for every individual, and the income disparity can be wide. So switching gears a little bit, I know some of you probably know a lot about diabetes, but it's good for us to have a refresher about how we define and diagnose diabetes. The formal term for diabetes is diabetes mellitus. And diabetes describes a condition of frequent urination. And there's actually two types of diabetes, diabetes mellitus and insipidus. For the purpose of our talk, we're talking about diabetes mellitus. And mellitus refers to honey or sweet in Latin. Centuries ago, physicians diagnosed diabetes by tasting the urine. And when an individual has diabetes and the glucose is high, they usually urinate out glucose in the urine, making the urine sweet. Lucky for me, currently we diagnose individuals with diabetes through blood testing. And there are 3 potential blood tests that you could have had to diagnose diabetes mellitus. That includes fasting glucose, hemoglobin A1C. Hemoglobin A1C refers to glucose attached to hemoglobin in red blood cells, and it reflects average glucose in the last 3 months. You may have also had something called an oral glucose tolerance test, where you drink a sugary drink and get glucose testing 2 hours afterwards. So all 3 glucose tests can be conducted to diagnose diabetes. There are different types of diabetes. The 2 main types include type 1 and type 2. And type 2 is the most common, with over 90% of individuals having type 2 diabetes when they have diabetes. To understand differences between different types of diabetes, it's good to review what happens in an individual without diabetes to control blood sugar. So here on the top, I'm showing an organ called the pancreas and one of your cells in your organs. Insulin is a very important hormone that helps control blood sugar. It binds to receptors on cells, allowing glucose, blood sugar, to be taken up into the cell. This is a very important process for certain organs in your body. In type 1 diabetes, your body destroys the cells called beta cells in the pancreas that make insulin. Therefore, it is very important that these individuals get insulin for treatment. Recently, we celebrated the 100-year anniversary of the discovery of insulin, which was a great modern therapeutic discovery. So in type 1, we need insulin for treatment. Type 2 is much more complex. There's both problems using the insulin that the body makes, as well as production of insulin. So this decrease in ability to use insulin is sometimes referred to as insulin resistance. You can sort of compensate for insulin resistance by making more insulin from the beta cells in your pancreas. However, if your pancreas cannot meet this demand, then the blood sugar cannot be controlled. It increases in your blood and you're diagnosed with diabetes. So in type 2 diabetes, there is both decreased action of insulin, insulin resistance, and decreased ability to produce insulin from your pancreas. Now, diabetes prevalence, as I alluded to earlier in the talk, the prevalence of diabetes is increasing worldwide and in the United States. This is some data from the United States dating back from 2001 up to 2020. Currently, the prevalence of diabetes in adults is approaching 15%. About 11% of individuals have diagnosed diabetes, meaning they are aware of their diabetes. And there are about 3% that are unaware of their diabetes and were found to have diabetes during these surveys. What does it look like when we disaggregate the data? Well, here I'm just showing 4 populations: non-Hispanic white, Asian Americans together, and Blacks and Hispanics. And again, I know some of these terminologies, people have preferences for other terminologies, but this is how the CDC and the NIH report the data. So if we look at diabetes prevalence, what we usually find is that in populations that are non-white, non-Hispanic white, the prevalence of diabetes is usually higher. So it's higher in Asians, Blacks, and Hispanics. And these bars refer to in red diagnosed diabetes and in gray undiagnosed. The other thing to note is that not only is the prevalence of diabetes higher, but prevalence of undiagnosed diabetes is also higher in non-white populations, especially in Asian Americans. There are some data that's disaggregated in Asian Americans. The year is slightly different than the one I showed on the previous slide, but it makes the same point. This refers to diabetes prevalence in individuals, and this is just diagnosed diabetes, not diagnosed and undiagnosed, just diagnosed. And again, you will see that in Asian Americans, diagnosed diabetes prevalence is higher compared to non-Hispanic white populations. But when you disaggregate the data, a common trend that we see is that the prevalence diabetes is highest in Asian Indians in America, as well as Filipinos in America. What explains this higher risk? Well, as I refer to some particular risk factors, keep in mind that the main mechanisms relating to diabetes go back to increase either in insulin resistance or decrease in insulin production. So some of the risk factors that are at play are true for all populations. And then through the talk, I'm going to be highlighting some that might be particular to Asian Americans. So genetics, your family history plays a significant role. And there's a lot of research at Stanford as well as globally to better understand the genetics driving risk for diabetes. Most of the genetic information that we know to date generally refer to decrease in beta cell function of your pancreas to make insulin. There's obviously also racial and ethnic underpinnings, but those are still evolving. The environment is also very important. And I want to remind you that environment starts in utero, just from the moment that you're conceived. The environment during birth, as well as outside of the womb, make a big difference for your risk for diabetes. And then I cannot stress enough the impact of lifestyle. I know this term sometimes people have heard it so much that they could discount it or say you've heard enough. But I would say the number one modifiable risk factor for diabetes is excess weight gain. There's also physical activity, sleep, lifestyle habits, just smoking, which affect risk for diabetes. And then something that we're learning more and more, not that we weren't aware of it, but it's become very important, especially during the pandemic, is how social determinants of health really affect how risk plays a role in patients' health and the diseases that they incur. And part of this, especially for Asian Americans, especially immigrating from other countries, is the effect of acculturation to the new country. I alluded to the fact that obesity is the number one modifiable risk factor for diabetes. So I think it's important to spend some time on what we mean by obesity. When I refer to obesity, what I'm thinking about is abnormal or excess fat accumulation that has an impact on someone's health. A screening tool for obesity, it's not perfect, is body mass index. You may be very familiar with body mass index. It's calculated based on your weight in kilograms divided by height in meters square. A common screening tool we use is body mass index, but I want to highlight that it does not diagnose body fatness or your health. So you may be aware of these cut points. These are traditional cut points for body mass index. There's several categories, including underweight. Some people categorize the next panel here as normal weight, but or healthy weight. But again, I want to say that body mass index is not equivalent to your health, but normal weight is considered 18.5 to 24.9. Overweight is 25 and above, and obese is defined as a body mass index of 30 or greater. Currently in the United States, over 70% of individuals are overweight or obese. Because a majority of individuals are in the overweight category, it's hard to call this category a quote unquote healthy category as normal weight. And then very important as it pertains to our talk today, in Asians, for a variety of reasons, these categories underestimate obesity, and it has been suggested that overweight be defined in Asian American populations starting from a body mass index of 23, not 25. Similar to the increase in diabetes incidence and prevalence, obesity is also increasing. It's probably a driver of the increase in diabetes. Currently in 2020, as I mentioned, over 70% of individuals are overweight and obese, and this is likely to increase in the next decade. So the greatest proportion of increase will be probably in individuals defined as being obese by a body mass index of 30 or greater. What is these criteria? How do these criteria look like in Asian Americans? So this is overweight prevalence, overweight. And I want to tell you, for this slide, I picked a slide where the cut point of 25 was used in all populations, just so you get a sense of the difference. So when you look at populations prevalence for overweight, which is BMI of 25 to 29.9, this is what it looked like in non-Hispanic white population in 2004 to 2006. It's higher than in Asian Americans, but when you disaggregate the data, there are certain populations that stand out, such as Asian Indian population and Filipino population in the United States. When you look at prevalence of obesity, defined as a body mass index of 30 or greater, you do see much more disparities, meaning it's much higher in a non-Hispanic white population than in Asian American populations. So individuals defined as being Asians in general do not have the obesity prevalence as defined by BMI. It doesn't mean it never occurs. So you can see there are proportions in Asian Indians, Chinese Americans, Filipino Americans that still meet this criteria, but it's not to the degree as it is in non-Hispanic white populations. However, I want to say that even despite those limitations, there is a relationship between obesity as defined by BMI. We're going to look at it defined by other metrics, but as defined by BMI and type 2 diabetes in all populations to date. And I'm just highlighting one study in a large population that had many different people from different backgrounds, including Asian Americans. And this is a busy slide. I just want to make a couple points. So this includes individuals who are white, Black, Hispanic, Asians, and others. And it's looking at different BMI cut points defined as underweight, normal weight, overweight, obese in each population. And then on the y-axis is risk of diabetes. And what you can see is in any population you look at, as BMI increases, the risk of diabetes increases. Let's take a closer look at non-Hispanic white populations compared to Asian populations. So when we look at this overweight category, in non-Hispanic white population, again, it's defined as BMI 25 to 29.9. In Asian Americans, the cut point was lowered to 23, as I mentioned. Even doing that, you can see the proportion of non-Hispanic white populations that were overweight, 35% compared to 47% Asian Americans. And then here's the risk of diabetes. It's 9.4 per 100 individuals in non-Hispanic white populations, and it's double that in Asian Americans, despite the fact that the BMI cut point was lower. That's also true as well if you look at the normal weight population. It's 5 out of 100 in non-Hispanic white populations, and it's double that in Asian Americans. I'm showing this graphically because I think it might be easier to see. So if you compare non-Hispanic white population to Asian Americans, as the BMI increases in these different categories, risk of diabetes increases in both groups, but it's much higher in the Asian American population. So what are some theories as why this occurs? Why is there a greater risk for diabetes at lower BMI in individuals of Asian American background, particularly in Asian Indian populations and the Filipino populations? So one theory is that the BMI underestimates the excess fat. So remember, I mentioned at the beginning of the talk that we use BMI as a screening tool for excess fat. And maybe it is a poor metric in Asian individuals, so that it suggested that the degree of fat is actually higher than predicted by the BMI. Other names for this phenomenon include normal weight obesity, metabolic obesity, metabolically unhealthy non-obese, and skinny fat. And this is a really old example, and a lot of people show this slide, but I think it illustrates the point well. This was something published in a journal in 2004, and it shows pictures of two physicians, one white, one of Asian descent. They have the exact same BMI, but when they have body fat measured by imaging, the body fat is about 9% in the non-Hispanic white physician versus more than double that in the Asian physician. The imaging that they did was this dual X-ray, and the darker areas reflect fat. I do also want to point out, and this is written in the descriptor for these physicians, is that the physician on the left here runs marathons, whereas the physician here claims not to be mostly sedentary. So there are other factors to this than perhaps your racial or ethnic background. So to look at that further, there's a ton of research looking into this. This was one study actually in a Chinese population in China, where they were trying to see if BMI underestimates the degree of fat in individuals. So they used BMI, but they also measured fat by this one bioimpedance measure. This is also not perfect, but it illustrates our point. So they divided individuals into 4 groups, and they used BMI and degree of body fat. So people here in the first bar were normal weight by BMI defined as 24 or less, and non-obese by body fat measurements. So this is normal. And then the next group is normal by BMI but high body fat. Next is overweight by BMI but normal body fat. And then the last category is overweight by BMI, but high body fat. So the first and the fourth bars are what you would expect. They align to how we think about the issue. And that also represents where most of the individuals are. So 47 were normal, and 37% were obese and obese. There was this category here where the BMI seemed normal, but there was high body fat, and that was 10%. And then the least common were overweight by BMI, but normal fat. And then on the y-axis represents risk for type 2 diabetes, at follow-up. And the highest was maybe what we expect, individuals with high BMI, high fat. But there is, again, a value maybe to evaluating degree of fat by a fat measure versus BMI in this category, which had the next highest risk for diabetes. And then it happened to be lower in individuals with normal BMI, higher BMI, but higher degree of fat. So there is an extra value perhaps to evaluating further a body fat measurement versus BMI. But in general, BMI tends to mostly categorize individuals in buckets that we expect. So there is a ton of research going on in this area, particularly as it pertains to individuals of Asian background. I just want to highlight some of the things that people are thinking about. So if we look at this imaging, there's a layer of fat that we call the subcutaneous fat. And obviously, most of my patients don't want any fat, but it's good to have a depot of fat where you can store extra calories that you need for the future. When we run into problems is when the capacity to store fat exceeds this area and may go into the intra-abdominal area and into your organs. So let's say a normal situation is you have subcutaneous fat, a certain amount that is there for a normal process to store your extra calories. An abnormal process may be that due to various reasons, the most common being overnutrition, you fill up the subcu fat to its maximum degree, and then the additional fat spills into your abdomen and into your organs, and then that leads to higher risk for diseases like diabetes. Other situations that people have evaluated is because perhaps individuals of Asian descent have lower BMI, maybe you preferentially, instead of using your subcutaneous fat, you tend to preferentially store fat in these depots in the abdomen and in your organs that are more aligned to risk for diabetes preferentially. There's also another thought that the subcutaneous fat may be underdeveloped in individuals of Asian background, leading to more fat being deposited in the abdomen and in your organs. And the organs that you may have heard about include your liver, but it can also be your fat, your pancreas, your heart. So there's a lot of research in this area. Another intriguing thought is that if you look at this graph on the left here, there is fat, but the major organ that makes up your weight is also your muscle. And there is some research going on to the fact that perhaps individuals of Asian descent have less muscle and greater fat. So the ratio of fat to muscle may be something playing into the role for risk for diabetes. Switching gears a little bit, a lot of people also talk about, obviously the environment is very important when it comes to risk for disease, but really starting from the intrauterine environment. One of the factors that might be important is undernutrition during fetal development. That has been associated with increased overweight status later on in life. There is thought that even though you inherit a certain number of genes from your parents, that this intrauterine environment is what leads to different gene expression. This could lead to increased risk for diabetes. Remember when we were starting out that the two pathophysiologic changes that occur in individuals with diabetes is insulin resistance, that this intrauterine undernutrition could lead to increased insulin resistance and maybe also decreased pancreatic beta cell development so that you are less able to produce insulin or increased insulin secretion. The other part of this intrauterine environment is maternal diabetes. So if your mother had diabetes during pregnancy, it could also lead to increase in type 2 diabetes risk. So there are intrauterine environment effects that may increase risk for diabetes. Interestingly enough, this is just an association, but the countries that tend to have the lowest birth weight, which may not always mean that there is under nutrition in utero, include Southern Asia, which has the highest percentage of individuals born of low birth weight. I didn't have specific percentages in India, but in the Philippines, it is also high, 20%. Compared to in the US, it's 8%, and it is actually fairly low in Eastern Asian countries such as China. I also mentioned maternal diabetes, also called gestational diabetes, and the prevalence of gestational diabetes is also high in Asian American populations. This is a study conducted in Los Angeles County. And when you look at our 4 groups, non-Hispanic white, Black, Hispanic, Asian, the prevalence of gestational diabetes during pregnancy is the highest in Asian Americans. And then when you disaggregate data, once again, the Asian Indian population has the highest prevalence, but it's also high in this particular study in women of Chinese background, Vietnamese, Philippine background as well. So I mentioned this factor of social determinants of health. It's really very important, someone's education background, access to healthcare, the neighborhood, and its effect on health. I've been showing you lots of bar graphs. I'm sure by the end of this talk, you probably will not want to see another bar graph. But again, looking at prevalence of diabetes in another time range, I've shown many such examples, but again, this is showing non-Hispanic white, Black, Mexican American, Asian. Again, the non-Hispanic white populations are the highest. What I want to show you on this slide is this refers to education. This is less than high school, greater than high school. And you can see that as you have increase in education attainment, the prevalence of diabetes is also decreased. And then the last section here refers to income, low, middle, and high. And again, income also associates with prevalence of diabetes. So there are a lot of factors, including this bucket called social determinants of health, that affect risk for disease like diabetes. I want to sort of put a lens on the sort of the 2 populations that I've been focusing on, American Asian Indians. This graph obviously is of the United States, and it shows areas where there are greater population of Asian Indians in the United States. I do think it's very important when you look at a population to sort of look at these social determinants. Obviously, not every single person in this category fits this exact mold, but American Asian Indians are unique for having the highest income among Asian Americans. They also have the highest percentage of college graduates, second only to those from Taiwan. They tend to have, again, I don't want to say everyone, but as a group have high paying occupations, including in computer science and in medicine. When you look at diabetes presentation, there tends to be a younger age at type 2 diabetes diagnosis. And I will say research is ongoing, but some of the mechanisms that have been uncovered, including from our own group, really show that the effect of insulin action, called insulin resistance, seems to be higher at any given BMI in individuals of Asian Indian background. And there's research, but I think it's less developed, about effects on beta cell function, especially happening at an earlier age. I also thought this graph was interesting in South Asians, looking at South Asian populations across the world, not just in the United States. And if you look at diabetes prevalence, it tends to be higher in South Asians compared to any of the majority ethnic groups in different countries, including UK, Norway, Singapore. The individuals coming from the Philippines or from Filipino backgrounds are not necessarily the same as all other Asian groups. This looks at the density of Filipinos in the United States, high concentrations in California and Hawaii. The socioeconomics for this group, again, high median income, the third highest among Asian Americans. 51% have graduated from college, jobs in healthcare and service sector. The presentation of diabetes, the rates seem to increase from first generation individuals immigrating to the United States to the next generation. And then there are data looking to see what happens in subsequent generations. And it seems that at least based on recent surveys, that lifestyle factors may be not as favorable in subsequent generations. There's this healthy immigrant hypothesis that the first generation may be the healthiest. It's only a hypothesis, so you can poke at me for this. And then based on one recent study I saw, there was increased overweight, obesity in subsequent generations, maybe poor lifestyle such as smoking, and actually decreased education attainment in subsequent generations. So you can see how it's important to have disaggregated data because not all Asian Americans are similar. And then looking back at some of the things we were talking about and how it differs in different populations, there's still ongoing research on genetic underpinnings. I think there needs to still be worked out how much of this environment, especially in utero, is having an impact. This creates, if you can imagine a vicious cycle where, the diabetes can be perpetuated from generation to generation. I still think lifestyle is important. I'm going to say something about that. And then again, social determinants and impact of that. So I left sort of lifestyle things to the end, but I think it is sort of the most important. And this particular graph here highlights how our diet has changed in the United States. And this is actually true in all countries, in India, in China as well. But if you look from 1970 to this was 2010, I don't have recent data, we have increased intake. The total amount of calories intake has increased by about 400 calories per day. And most of this is in not so healthful ways. We're eating more refined grains, more animal fats, and more sugar. And there's been a lot of focus on increase in sugar sweetened beverages. I want to talk about rice because this, for my patients, rice can be emotional. It's definitely a staple in Asian American diets. This study, which was conducted in several countries, not just in the United States, looked at risk of diabetes and rice intake. It's highest in South Asia, and it's written here as grams per day. And they said 1 unit was about 150 grams. That can be about 3/4 to a cup of rice. And it's highest in South Asia. And the particular rice that may have the highest risk for diabetes is white rice, which has undergone a polishing process, and it can alter the rice by removing some of its main nutrients. And the greater increase in rice has been associated with increased risk for diabetes, but not in all populations. In this particular study, it was strongest for South Asia. There were some trends in Southeast Asia, but not in China. So, I just bring it up because it is a staple in Asian diets. And then I'm leaving you, I think, with more hope. I don't want you, if you're worried about diabetes, to be depressed by this data, because even if you have genetic risk for diabetes, lifestyle makes a huge impact. This was a study conducted in predominantly Chinese population, looking at diet, and they classified diet as healthful, intermediate, unhealthful. They also looked at genetic risk by looking at certain genes that we know are associated with increased risk for diabetes, and they classified individuals as having low, middle, or high risk. So low, middle, or high risk. And you can see that if you have an unhealthful diet, you're at higher risk all around, regardless of your genetic risk. But if you have a healthful diet, you can moderate this risk. So I do think, your lifestyle, you have a lot of control in affecting how genetics plays out. Obviously, genetics does have a role as well. In this particular study, healthy was defined as having a BMI below 24, having a healthful diet, high physical activity. The other thing I want to leave you with is there have been several studies looking at diabetes prevention, large studies conducted in the US and other countries. This happens to be one in China, looking at the effects of diet and exercise, or diet plus exercise, in individuals with pre-diabetes. So not normal glucose, not diabetes, but sort of in between. And what they found was that compared to doing nothing, which is the control group, if you changed your diet, or if you exercise, or if you did both, you can lower your risk. And it was true in individuals defined as being lean. Here it was defined as BMI less than 25 or over 25. And there are components of the diet that they focused on: decreasing that refined carbohydrates like rice, increasing vegetables. In this particular study, they only focused on weight loss in overweight individuals, but there actually wasn't a great degree of weight loss in this particular study. And then there was a big increase push for exercise. The nice thing about this study is they published their 30-year follow-up. So they followed this cohort for 30 years, and the benefits seem to persist. So in red here is the control group, and then they collapsed the intervention group. People got diet, exercise, or both, and the risk of diabetes was lower, risk of cardiovascular events was lower, deaths was also lower, and there are these things called microvascular disease, like eye disease, kidney disease, nerve disease, was also lower. You may be asking me why I didn't focus on populations such as Filipino Americans and Asian Indians. There are studies in those. I felt that they were less developed, but the themes are generally the same. Lifestyle generally helps lower risk for diabetes in all populations. So I hope your eyes aren't cross-eyed from all these bar graphs, but I want to conclude by saying that risk for diabetes is higher, actually, in all non-Hispanic white groups, in Asian Americans particularly, especially in certain groups, Asian Indians and Filipinos. I still think, even though there's flaws to the body mass index, it associates with risk for diabetes, but it can underestimate risk in Asian Americans compared with non-Hispanic whites. I hope I showed you that changing your lifestyle can lower risk, and this includes, your diet, physical activity, weight loss. But it can also include things like sleep or habits such as quitting smoking. And of course, we really need additional research, and we really need to disaggregate data for Asian Americans, because as you can see, there are unique features to different groups from different countries. Thank you.
Thank you so much, Dr. Kim, for an enlightening talk. Very popular talk as well. We have many questions, so just a note to the audience, please put your questions in the Q&A. I know some people put it in the chat, but it makes it a little easier to manage if you could put your questions in the Q&A. We'll try to get to all of them if possible. Just to note as well in the chat, Nina Lee, our program coordinator for community health for care, has put some links to our Nourish project, which is a project on Asian diets and healthy eating. You can also go to our website, care.stanford.edu. First question, is insulin treatment a foregone conclusion for those diagnosed with type 2 diabetes? What types of drugs can postpone insulin?
Okay, so a very good question. You know, there's really been an explosion of therapies for type 2 diabetes in the last 10 to 20 years. And I don't think insulin is a foregone conclusion. I think, you know, lifestyle is very important, but there are other drugs. I'm not sure if you want me to go into specifics, but there are drugs called GLP-1 receptor agonists that can really help with even, you know, weight loss and control of your glucose. There are even these other categories called SGLT2 inhibitors. And so I think, you know, the therapeutics are continuing to be developed. I know a lot of people fear insulin. One thing I do want to say about insulin is if you need insulin, don't try to delay it. I think there are different reasons people have diabetes and develop high glucose, and some people need insulin. So don't have it in your mindset that that's a failure for you if you need insulin, because that may be the right treatment for you.
Perfect. Very, very amazing time we live in. There's so many new treatments for diabetes. Yes. Next question, is there a genetic test for propensity for diabetes?
Yes. So there are lots of different panels that you can look at to determine sort of your risk. And so what we call type 2 diabetes, it's very common, and there usually are not one gene that explains your risk for diabetes. There's several genes, so we call it polygenetic. There are certain types of diabetes which I didn't discuss. Some people call them MODY because it's monogenetic. There's one gene, but the more common scenario is that there are many genes that explain your risk for diabetes. So some of the studies I showed where they were looking at genetic risk, they were looking at lots of genes and sort of adding up the scores. But there are several companies doing that, and I hope Stanford will offer it as well. But currently, even though it seems like that's where we're headed in the future, and we definitely are, the genes that we are aware of don't explain a majority of any individual's risk for diabetes. It definitely can divide people who are at higher risk, but doesn't completely explain your total risk for diabetes.
Great, thank you. Thank you for that insightful answer. Next question relates to Asian foods. How do Asian foods specifically contribute to diabetes risk?
Yeah, so it's so interesting. It's hard to study foods sometimes because there's so many components of your food. I do think modern Asian foods or comfort Asian foods definitely. I'll give different examples. If you have diabetes, and if you've ever evaluated your glucose eating certain Asian foods, you will know which ones really increase your glucose. And I will tell you, bar none, white rice, dim sum, you know, ramen, and then manto, you know, those steamed buns. I guarantee you, if you have diabetes, that will increase your blood sugar. But whether in a population without diabetes, constant consumption, will that increase your risk? That one study I showed that, you know, the greater number of servings of rice that you ate could increase your risk. But I wouldn't say, you know, is that the major driver? I just think if you are predisposed to diabetes, if you already have prediabetes, those types of foods first are less helpful than, let's say, vegetables, fruit, whole grains. And, you know, a lot of Asian populations used to eat more whole intact grains, and we've just kind of moved away. Like, I think globally, we've moved away from really helpful foods to quick comfort, easily available, more processed foods. So I think this is a global trend, not just focused on Asians, but there are certain foods that we all love that are super popular that are probably not as helpful for you, especially if you have risk for diabetes.
Great, excellent. Next question, I'm going to paraphrase this because I think you answered this in your talk, but in terms of lifestyle contribution to diabetes, is it sort of all or nothing? Is it, exercise, no exercise, or is there a gradation of, if you walk a mile a day as opposed to, being a marathoner, does that help lower your risk? Is there kind of diminishing returns? Can you talk about lifestyle and degree of how much you need to do to reduce your risk?
So I would, not, preach to anyone, but Dr. Lin knows too. I tell patients all the time, like, what do you think you can handle? How can we change your habits? So it's obviously, the more you do, the better, but I don't want you to feel overwhelmed. I think you should take steps to figure out how can you incorporate this into your life, and can you do more? Can you do more? But I think a good combination, if you are overweight, definitely working on weight loss. And then along with that, more healthful foods. Can we focus first on like trying to lower added sugars and then maybe switching off some of your refined grains to whole grains? Could we, work on adding more vegetables? But steps that you can take, you can keep building. And I think, anything you can do is better than, not doing. But I know it's not easy. It's not easy to change habits, right? So I think anything helps, but there are definitely like, I'll give you an example with weight and diabetes. Any little bit you can do will reduce your blood sugars. However, if you want to have a meaningful impact, I think definitely, trying for a 10% is, very significant weight loss in someone, with diabetes. But please take the message that take any steps and pick one.
Great, so great, very sound advice. I'm going to combine the couple of the next questions are more about related to substitutions and touching on your what you'd mentioned about whole grains. Is brown rice good enough? Do you still have to eat less? I get this question a lot. Well, instead of eating white rice, I'm eating brown rice. Is that okay? Can you eat more then? And then related to that, there was a question about pasta and noodles. Is that also similar, where if you eat whole wheat pasta or whole wheat noodles, is that also beneficial, or what do you think about that?
Right. I think if you're going to eat carbs, replacing brown rice with white has some benefit, and there's been research for that. However, they're all in the carb category, so you cannot eat an unlimited amount. And so I think the amount is also important. But if you're gonna eat it anyways, replacing is better, because there are whole intact grains that's becoming a little bit more popular, like millets, which is kind of an ancient grain, quinoa, and so if you can't just start eating those for health in addition to everything else, it's more of a replacement for white rice, and I think that would be beneficial. But you have to still think about the amount.
Very important. Still got to think about quantities and serving sizes. I'm going to, again, also combine the next couple of questions because they're around A1C. First, what is A1C? What are the numbers we should be targeting? And then second, the viewer, the member of the audience said their A1C was 15 years ago was 6.0 to 6.2. Changed their diet, same, A1C 6.0. Is pre-diabetes a condition? Does it really, how meaningful is it, especially as you get older, as a risk factor?
Okay, very enlightened questions. First, hemoglobin A1C refers to glucose, I'll just say crudely, stuck onto hemoglobin, which is part of your red blood cells. And your red blood cells, last in your body about 3 months. So it reflects average glucose in the last 3 months. Normal hemoglobin A1C is less than 5.7%. And then 5.7 to 6.4 is pre-diabetes, 6.5 and above is diabetes. But we don't just make, diagnosis maybe just on that one metric, if that's the only one that you have abnormal. It needs to be verified, and you could also use it in conjunction with your blood sugar data. For the person who asked that question, what is the relevance of prediabetes? Prediabetes definitely is a risk factor for development of diabetes. And it depends on how high you are. And the fact that you stayed 6 may be attributable to the fact that you engaged in lifestyle change. For example, in patients with pre-diabetes, especially ones, at the higher end of higher glucose or higher glucose after eating, after that glucose drink, what we know to date is conversion to diabetes is about 10% per year. So 10% per year. And so if you've been able to maintain your range for 10 years, it's possible that, you are working toward. A lot of my patients, they want to get to normal. And if they stay in the same place, they're disappointed. But, I always say, I wish there was a metaverse where you could see what would have happened to you if you didn't care about it. You may have developed diabetes, and the fact that you're staying there is a good thing. However, there is controversy. Some people think we're over-diagnosing prediabetes. Some people feel that in older populations, because in a population over 65 in the United States, 50% qualify for prediabetes. So it's a very common state. I'm actually right now working on a large database to, better understand, the risk to develop diabetes if you have prediabetes. I still think it is, a risk factor. You may not consider, some people don't consider it a disease of itself, but a risk factor to develop diabetes.
Great. Fantastic response. Very, very nuanced. A great question. From our next viewer, is there a finite lifetime insulin secretory capacity to the pancreas? If a young person grows up eating a high carb diet, is that person draining the ability of the pancreas to respond to carbohydrates in the future?
So very, very good question. And something that, people are still trying to understand, but people do feel that you are stressing the pancreas. So, if you start off at a young age, if you already sort of have risk factors for diabetes, you have a poor lifestyle, maybe with high sugar content, but you also get obese and you're insulin resistant. So you're taxing the pancreas to make more insulin. Some people do feel that that adds to your risk for developing diabetes by taxing the pancreas. It's hard to necessarily prove that, but I will tell you, individuals, with diabetes at, time 0, by 10 years, a lot of individuals need, 2 or 3 medications for treatment. And some people call this, progressive deterioration of your beta cells. But then, other studies, actually, I'll give you a really good example is, I didn't talk about it in this study very much, but, if you are overweight or obese, losing weight has a tremendous impact on diabetes control. And there's surgical options for weight loss, which can help you reduce your weight by 30%. And in certain individuals, losing 30% greatly improves insulin resistance to the point that your pancreatic beta cell function is enough at that point that your blood sugars get better controlled and you may be able to get off your medications. But that seems more true the earlier you get diagnosed with diabetes, especially in the first 5 years versus maybe past 10 years, past the time that you're already on insulin. Kind of answering that question is, at earlier time of diagnosis of diabetes, you may have a greater opportunity if you make lifestyle changes to really help your body to the point of allowing your own pancreatic beta function to work, and that you may not need medications. But however, the longer you wait, maybe the effect on the beta cell is such that the function of the beta cells cannot meet the demands at that point later on in the diagnosis of diabetes. I didn't quite say that as well as I could have, but to the point, I do think there's some merit to the time involved with the habits that you carry. And when you know you have diabetes, I will tell you that is the time to make the greatest action.
Thank you so much for a really enlightening evening, Dr. Kim. We do have more questions, but I think unfortunately we're running out of time. So please join us next month. We are going to have a next community health talk, nasopharyngeal carcinoma, what it's about, who gets it, and what we're doing about it with Dr. Dimitrios Polivas. Please join us then. And again, great thanks to Dr. Kim, and great thanks to the Stanford Health Library, and also great thanks to the Vincent V.C. Wu Foundation for sponsoring this series. Have a great week, and we'll see you next month.
Thanks, Dr. Lin.
Great, thanks.